Okay, good morning. Hopefully everyone can hear me, and if you can't, please go to your question box on your control panel and just let us know that you're having some difficulties. So I'd like to thank you all for joining us for the CREMS webinar series. And the focus of our webinar today is going to be exploring predictors and patterns of long-term mental health and heroin dependence. And we have Dr. Christina Marel joining us for that topic. My name is Lexine Stupinski and I'll be chairing the session today. And we'd like to encourage you to put forward any questions that you might have during the session. So if you just use the question panel that I mentioned earlier to submit any questions that you have, and then at the end of the session we will be having a Q&A session where Chris will answer any questions that come through. So now this is the first in a series of webinars that we have scheduled for 2016. So as you can see on the slide, and the program covers a range of topics focused on understanding, preventing and treating mental health and substance use disorders. And the topics that we have this year will include, in May, we have Associate Professor Tim Slade, who will be talking about friendship networks in adolescence and looking at how they evolve and how they might influence mental health and substance use. And then in October, we will have Dr. Joanne Ross talking to us about behavioural activation for the treatment of depression among substance users. So two really interesting topics coming up, and we will have additional webinars scheduled over the year as well. And full details about these webinars are available at our website, so comorbidity.edu.au training webinars. And you can also sign up to join our mailing list to be notified about future webinars. And just to add that if you missed any of the topics that we covered in 2015, these are all available on demand. So you can go to our website, you can view the video recording. So today's webinar is being recorded, but all of those previous webinars have been recorded and you can view those and also download the handouts from our website. Now, in just a moment, I'll introduce our speaker for today, but before I do, just a quick overview for those of you joining us for the first time about who we are at CREMS and what we do. And so CREMS stands for the NHMRC Centre of Research Excellence in Mental Health and Substance Use. And what we're all about at CREMS is conducting research to improve our understanding of mental health and substance use disorders, and in particular understanding how and why these problems co-occur. And in addition, we're working to develop improved strategies and researching the most effective ways to prevent and treat these problems. So to achieve these aims, we work closely with services, schools and community groups, and this webinar series is another way in which we can foster those lines of communication. And so this is just a photo of our team at CREMS, and you can see there in the very bright pink is our director, Professor Marie Thiessen. And so now I'd like to introduce our speaker for today. So we're very lucky to have Dr. Christina Marel to present for us. And she is a research fellow at the National Drug and Alcohol Research Centre at UNSW. And her research focuses on improving our understanding of and responses to co-occurring substance use and mental health disorders in complex populations, and also understanding individual periods of risk. And she is committed to translating the findings of her research and recently led the revision of the Department of Health funded guidelines for management of comorbidity. So I will pass over to Chris now, and she's going to be talking to us about predictors and patterns of long-term mental health and heroin dependence. So thank you, Chris.
Thanks, Lexine, and thanks so much for joining us today. So as Lexine mentioned, I'm going to be talking about a program of work that's been underway for the last 15 years, and that examines long-term patterns of heroin use and mental health, and also the long-term predictors of these behaviours over time. The work's being conducted through the CREMS program at the National Drug and Alcohol Research Centre. So in terms of how I've structured today's presentation, I'm going to first talk a little bit about the background of heroin, and this will provide a bit of context for the rest of the talk today. I'll cover what it is, the effects, the harms and burden, the prevalence, who becomes dependent, and the available treatments. I'll then talk a bit about the patterns of heroin use and mental health over time, which is when I'll draw on findings from a longitudinal study which has been running through CREMS, followed by the predictors of heroin use and mental health over time. I'll then talk about the implications and future directions. So many people might be aware of what I'm going to cover in the first half of the talk today, but I'll go over it, a bit of the background information for those who aren't. So first of all, what do we know about heroin? Well, we know that heroin sits beneath the broader opioid umbrella. Opioids are a class of drugs that include the natural products of the opium poppy and its synthetic compounds, as well as heroin. This class includes drugs like morphine, codeine, methadone, oxycodone, and fentanyl. Opiates have a long history of both medicinal and recreational use, dating back to at least 4000 BC. However, we really began to see an increase in the use of these drugs in the 1800s because of three key events, which were the isolation of morphine, the invention of the hypodermic syringe, and the synthesis of heroin in 1874. Heroin was sold as an over-the-counter cough suppressant between 1898 and 1910, and in fact, the name heroin is derived from the German word for heroic. So one of the primary clinical characteristics of opioids is that they reduce pain or produce analgesia, and are often referred to as narcotic analgesics. They also suppress the cough reflex and are often used in over-the-counter cough medicines. They can also induce drowsiness and sleep by binding to a complex group of neuroreceptors, and importantly, they can produce a rapid sense of euphoria and detachment, which is often referred to as the rush people experience about 20 seconds after they inject heroin. The rush involves feelings of warmth and pleasure, followed by a long period of sedation. And although injection is associated with the most rapid onset of effects, smoking heroin produces effects that are almost as quick. Heroin is excreted by the body as morphine, and the half-life is about 2 hours. And I'll talk a bit later about longer-acting opiates such as methadone and buprenorphine, which are used in the treatment of heroin dependence. So although opioids are associated with some pleasurable effects, they of course have negative effects as well. Before tolerance has developed, use of these drugs can result in nausea and vomiting. The gastrointestinal tract has reduced movement, and this can result in chronic constipation. But one of the primary concerns is that opioids are a central nervous system respiratory depressant, and this reduces or suppresses the rate of respiration. So an overdose, breathing can reduce to rates of 4 breaths a minute if the person lives, and the 3 critical signs of opioid toxicity are reduced levels of consciousness, pinpoint pupils, and depressed rate of respiration. The person might also look a bit blue, have reduced blood pressure, a slow heartbeat, and be hypothermic. And the death is usually due to respiratory failure. People who've been using heroin over the long term are usually in their 40s and 50s and typically have incredibly poor physical health. Older heroin users will likely have chronic medical problems, which may include the liver, lung disease, cardiovascular system, and vascular problems. Long-term heroin users are also described as aging at an advanced rate, for example, developing arthritis earlier than their non-using age group, which can make those in their 40s and 50s look like they're an elderly population. So although the prevalence of opioid use is relatively low, and I'll talk a little bit about this in a minute, opioids carry the highest degree of harm. Some of the harms of opioids include premature death, with mortality rates more typical of what you'd expect to see of the elderly. The risk of overdose also contributes to premature death, and non-fatal overdose is associated with serious health effects such as brain damage and cognitive impairment. Smoking or injecting heroin is also associated with poorer physical health due to viral transmission, vascular damage, and pulmonary disease. Mental health is also poor, and it's been estimated that at least half of any group of heroin users will qualify for a psychiatric diagnosis, most commonly mood, anxiety, or personality disorders. High rates of criminal involvement are also common, as are low levels of education and high rates of unemployment. So in general, this group of people is dysfunctional, very ill, highly disadvantaged, socially marginalized, with a large burden of disease. And this is a very long way from the heroin chic images that dominated advertising in the 1990s. So it's very difficult to estimate the prevalence of heroin dependence because many of the surveys we use for capturing drug use, like the National Drug Strategy Household Survey, don't include hidden populations like the homeless, those in prisons or institutions, or other marginalised groups who often have high rates of drug use. So most estimates of heroin dependence are likely to be an underestimate. But compared with other illicit drugs, such as cannabis, the prevalence of opioid use is relatively low. It's been estimated that 15.5 million people worldwide are opioid dependent, and this is about 0.3% of the global population. The highest prevalence of opioid dependence is in Asia and Australasia. And in 2013, an estimated 1.2% of Australians aged 14 and over had used heroin in their lifetime. Although there have been fluctuations in use over the past 20 years, rates of heroin use in the Australian general population decreased from 1993 to 2013 by 0.5%. In 2013, a study looking at the global burden of disease found that opioid and amphetamine dependence were the two most common forms of illicit drug dependence worldwide. And males were approximately twice as likely than females to be using these drugs. The same global burden of disease study estimated that opioid dependence was associated with 7 million years of life lived with disability, which was 3 times the disability associated with cannabis and amphetamines, and 7 times that of cocaine. Opioids were associated with almost 2 million years of life lost, which was 76 times the years of life lost associated with cocaine and amphetamines. So this means that opiate dependence accounts for the highest proportion of all illicit drug burden worldwide. And to calculate these estimates, this study looked at data from 187 countries between 1980 and 2010. A recent report from the US Center of Disease Control and Prevention highlighted an increase in heroin use and dependence across the US over the past 10 years. Between 2002 and 2013, the annual average rate of past year heroin use has increased by 62.5%, and heroin dependence has increased by 90%. Rates of heroin-related drug overdose deaths has also substantially increased, rising by 286% between 2002 and 2013. But why is there such a big burden associated with opiate dependence? Although cannabis is the most commonly used drug, the rates of cannabis dependence worldwide are lower than amphetamine or opiate dependence, and the highest estimated global burden is associated with opiate dependence. And this is largely attributed to some of the factors that I mentioned before, which includes premature mortality, high disability, and the large population of dependent users. The disability-adjusted life years, the life year estimates for opioid dependence are about 8 times that for cocaine and 4.5 times that for cannabis dependence. So in terms of how many people become dependent, heroin is highly addictive. It's been estimated that 1 in 4 people who use heroin will become dependent, which is second only to tobacco. And there's been no difference between males and females in terms of who becomes dependent. Once heroin was used, dependence was equally likely for males and females. Cocaine, alcohol, methamphetamine, and cannabis were all substantially lower in their abuse liability than heroin. And this means that any use of heroin is associated with considerable risk of future dependence, which is higher than almost any other substance. So when thinking about who becomes dependent, it can be useful to think about who seeks treatment. The most common drugs of concern that people sought treatment for in Australia between 2003 and 2014 were alcohol, cannabis, amphetamines, and heroin. Between 2003 and 2014, amphetamines and heroin have replaced each other as the third and fourth most common principal drugs of concern several times. And among people seeking treatment for heroin as their primary drug of concern, 2/3 were male, 10% were Indigenous Australians, the majority were aged between 30 and 39 years, 63% reported additional drug use, which was primarily cannabis and amphetamine use, 83% injected heroin, and most were self-referred into treatment or referred by family. So in terms of what treatments are available, in general, treatment falls into 3 categories. Firstly, Detoxification is a short-term intervention that removes toxins from the body and deals with the physical side of dependence. Withdrawal is managed in inpatient or outpatient environments. Drug-free residential rehabilitation is a long-term holistic treatment which follows a period of detoxification where residents are unmedicated. Residents change their lifestyles completely, and this involves abstinence from drugs, developing employment skills and self-sufficiency. Programs usually between 3 and 12 months. Maintenance therapies, or pharmacological maintenance, involves outpatient opioid substitution therapy, and this is often the most popular treatment. Methadone essentially replaces heroin, and although heroin can still be taken, larger amounts are needed to gain the effect because of methadone's blockage of opioid receptors. Buprenorphine, or Subutex, has been available in Australia since 2001, and this is increasingly popular. Suboxone is the combination of buprenorphine and naloxone, and this is the drug responsible for reversing opioid overdoses. The naloxone is only activated when injected, and this will induce acute opioid withdrawal. So as I mentioned before, both methadone and buprenorphine have longer half-lives than heroin, and this means that people can receive their dose daily or every second day. And there's no best method. No one type of treatment will suit everyone, and people will often need to try a number of different options before finding what will suit them. So just to quickly recap over what I've covered so far before we move on. Although the prevalence of heroin is relatively low, the burden is disproportionately high, and use and dependence are associated with high rates of morbidity, mortality, and other adverse outcomes. Trends in use, dependence, and overdose deaths have increased significantly across the US, but heroin use has shown a small decrease in Australia over the last 10 years. Heroin is highly addictive, and in general there are 3 primary treatments that are available. So now I'll move on to the patterns of heroin use and mental health over time. Given that heroin dependence is a persistent, chronic, and often lifelong condition that's associated with significant burden and harm, it's really important for us to have information on modifiable risk factors across the lifespan. And what I mean by modifiable risk factors are characteristics that can change. So, for example, homelessness, involvement in crime, use of other drugs, or mental health, which might have an effect on heroin dependence over time. Having more information about which risk factors might be linked to long-term heroin use would provide information about how treatment could be targeted to address these risk factors. So to give us the opportunity to study the effects of heroin dependence over time and to see whether any risk factors were linked to change in heroin use, in 2001 we started the Australian Treatment Outcome Study, or ATOS. ATOS was a prospective, longitudinal cohort study, meaning we followed the same people over time, and it was one of the few studies to focus on heroin dependence alone. In 2001, we recruited 615 participants from around Sydney, 535 who were entering treatment for heroin dependence, and we also recruited 80 people who were not entering treatment from needle and syringe programs around Sydney. We followed up our ATOS cohort at 3 months, 1 year, 2 years, 3 years, and 11 years. However, there was a substantial increase in the number of people who had died between 3 and 11 years. Similar to the types of people who presented to treatment that I mentioned earlier, the ATOS cohort was fairly typical of people who presented to treatment for heroin dependence, which is to say they were 2/3 male, they were just aged less than 30, the mean age was less than 30, almost all were heroin dependent, and that was because of the nature of the study. They had been using heroin for about 10 years, and there was a fairly high amount of polydrug use. At 11 years, the cohort was still 2/3 male, they were 11 years older, almost 1/4 had used heroin in the last month, and just over 15% were heroin dependent. Almost half were still in treatment for heroin dependence, and this was primarily maintenance pharmacotherapy. And crime, as the main source of income in the last month, had decreased to 2%. The mean age where participants first got high was just over 13. Participants were 19 when they first injected any drug, and when they first used heroin, 20 when they first injected heroin and began using heroin regularly, and that was more than once a month. So I won't go into too much detail here, but over the 11 years, all participants spent some time in treatment for heroin dependence, with a median of 4 years in treatment over the 11 years across a median of 4 treatment episodes. In terms of patterns of heroin use, dependence, and other drug use, these all decreased over the study period. with the most dramatic reductions evident in the first 3 months of the study. For the most part, these reductions were maintained over time, with the exception of other drug use, which increased between 3 and 11 years to reach almost baseline levels by 11 years. In terms of alcohol and other drug use, there was a high amount of polydrug use at both baseline and 11 years. However, at 11 years, 1/4 had not used any heroin in the last month, and more than 1/4 had not used any illicit drugs. In terms of risk-taking behaviour, and this was daily injecting drug use, borrowing needles, and overdose, these all decreased over the follow-up period, again with the most significant reductions evident in the first 3 months. In terms of abstinence from heroin use, half of the cohort maintained abstinence for 6 years or more. And important to note here is that the majority of the cohort achieved substantive periods of abstinence of more than 3 years. We also conducted a search of the National Death Index after all interviews had been completed, and we found that 11.7% of the original 615 had died, and this was mostly due to accidental overdose. So in terms of the mental health of participants at baseline, 1/4 had major depression, almost 1/3 had current post-traumatic stress disorder, 50% were classified as having severe mental health disability, and just over 10% had attempted suicide in the year prior to interview. At 11 years, major depression had reduced to 1 in 5, current PTSD had reduced to just over 20%, severe mental health disability had reduced to 1 in 4, and 2% of the cohort had attempted suicide in the past 12 months. In terms of severe disability over time, while there was a significant improvement in severity of mental health disability over time, again with the greatest improvements evident in the first 3 months of the study, there was little change in severity of physical health over time. And by 11 years, physical health severity looked very much the same as at baseline. In terms of major depression, this decreased significantly between baseline and 3 years, again with the most dramatic reductions evident between baseline and 3 months. However, by 11 years, major depression had increased to almost baseline levels. So again, just to recap, because I know I've just thrown around a lot of numbers, the mental health of participants at baseline was very poor. 1 in 4 had major depression, almost 1 in 3 had current PTSD, 1 in 2 had severe mental health disability, and 1 in 10 had attempted suicide in the year prior to interview. By 11 years, heroin use, dependence, and risk-taking behaviour had all significantly decreased, and half of the cohort had maintained abstinence for 6 years or more. More than 1 in 10 had died, mostly due to accidental overdose. 1 in 5 had major depression, 1 in 5 had current PTSD, 1 in 4 had severe mental health disability, and 2 in 100 had attempted suicide in the year prior to interview. So now I'll talk a little bit about the predictors of heroin use and mental health over time. In terms of factors that were consistently associated with heroin use, heroin dependence, and other drug use over time, we found that not having commenced residential rehabilitation, having entered detoxification, and major depression were consistently associated with heroin use. Heroin dependence was consistently associated with not having commenced residential rehabilitation, having entered detoxification, more treatment episodes, borderline personality disorder at baseline, and major depression. Other drug use was consistently associated with being male, not having entered residential rehabilitation, having entered maintenance therapies, and major depression. And important to note here is that residential rehabilitation is common to all three, as is major depression. In terms of what was associated with improvements in general physical health over the 11 years, meaning that there was a consistent and long-lasting relationship across the study, we found that being male, younger aged, not having entered detoxification, having entered residential rehabilitation, the absence of PTSD and major depression, and the absence of antisocial personality disorder at baseline were associated with improved general physical health. Being younger, not having entered detoxification, having fewer treatment episodes, the absence of major depression, and the absence of antisocial personality disorder at baseline was consistently associated with improved general mental health over the 11 years. And important to note here is the commonality of major depression and detoxification over time. So over the 11 years, major depression was consistently associated with heroin use, heroin dependence, other substance use, having shared needles, injection-related health problems, criminal involvement, poor physical and mental health. So finally, I'll just talk about what the implications and future directions of this work are, or in other words, what it all means. Firstly, over the study period, we found that major depression was the single most influential factor for poor outcome, and we found that it was significantly associated with every outcome we examined. Those who were depressed were consistently more likely to be using heroin and other drugs, be heroin dependent, sharing needles, experience injection-related health problems, be involved in crime, and have poorer physical and mental health. Major depression also had a stronger relationship with heroin use, heroin dependence, injection-related health problems, and poorer physical and mental health than any other factor we examined. So although we can't determine causality, we can't see from the study whether depression causes poor outcomes or vice versa. The consistent and long-lasting relationship really highlights the need for targeted interventions. Secondly, the ATOS study is really reflective of an aging heroin-dependent cohort with poor physical health and multiple co-occurring conditions. So as the cohort continues to age, there will really be a need to develop and deliver comprehensive treatment which has the ability to address both physical and mental health needs. Thirdly, the findings showed that commencing residential rehabilitation was consistently associated with positive outcomes across a number of domains. In particular, commencing residential rehabilitation was the only factor that was related to improved physical health. Along with fewer treatment episodes, the findings really highlight the importance of stability in treatment for heroin dependence. And finally, the association of detoxification with poor outcome over the long term indicates that detoxification may be used as a gateway into other treatments rather than a standalone treatment. But it's really important to remember, if nothing else from today, that although heroin dependence is often a long-term chronic condition with a high mortality rate, our study showed that people can and do get better. So in terms of looking into the future, it's also important to remember that co-occurring mental health and substance use disorders don't have a quick fix solution. More often than not, they're chronic, long-term relapsing conditions. So this slide illustrates some trajectories of heroin dependence within, or patterns of heroin dependence within a US cohort study, and shows 4 different pathways of heroin over a 30-year study period. You can see that there's two distinct pathways that lead to maintained abstinence, one that shows no decrease in heroin use, and one that shows moderate decrease over time. So as I said at the beginning of the webinar, being able to identify risk factors and specific periods where people are vulnerable to relapse, overdose, remission, and becoming involved in crime and mental health conditions can potentially help clinicians by providing opportunities for the timing of targeted interventions, which can potentially change a person's trajectory and minimize their risk. And this is what we're in the process of doing with long-term data from ATOS. So I'd just like to thank our funders and collaborators and also point out our website, which Lexine mentioned at the beginning of the webinar, if you'd like to check out any resources, additional study details, which I've mentioned throughout the talk, and I've also got some references at the end, or any other details of papers, published links to other studies. Thank you.
Okay, thank you so much, Chris. That was really fascinating. And we've got a few questions that have already come through. It's such a positive, hopeful story as well, so that's the great thing. So just going back though, first of all, we've got one question about the data you presented earlier about the burden of disease in terms of years of life lost. Mm-hmm. And in particular, so you're talking about how heroin was such a large burden of disease. Is that mostly due to heroin and strong opioids, or do the over-the-counter meds such as codeine also play a role in that, do you think? And I know this isn't your data, so you might not be able to answer the question.
That's a good question. The Global Burden of Disease study looked, I think, at opioids in general. I'm not actually sure. I've got here some references that would provide more information. The Louisa Degenhardt's papers here, the Global Burden of Disease, I believe because it's talking about illicit drug use, it's not talking about over-the-counter opioids, it's talking more about opioids. I mean, it's talking about opioids, not just heroin, but I don't think it's including over-the-counter opioids.
Yeah, but maybe check the paper. Yeah.
Yes, but I would recommend just double-checking that. Sorry, I can't be more help with that.
No, that answers it. Okay, here's another one about the guidelines for comorbidity. So when is the next version due for release?
We just received funding confirmation last week that we have funding to disseminate them across Australia, which is great. So once we receive, it's just been executed, so once we receive that and we're able to finalise the contract with our printing brokers, we will get onto that. So it'll be in the next few weeks, I hope.
Okay.
And we'll be able to release, we just have to confirm the launch date with the Department of Health, but it'll be very soon, I hope.
Yeah, and there'll
Thank you, everybody, for being patient.
and there'll be a training package similar to last time around that?
No, there will be a training package. It'll be a bit different from last time in that we're going to be developing an online package this time, not having a train-the-trainer package. Last time we had a train-the-trainer who travelled around Australia. This time we're going to be developing an online training package that will, we've got to iron out the details, but I believe we're going to be doing something via a website, which I've got to work out, but that's the idea at the moment.
And while we're talking about guidelines...
But you could free to, sorry, I was just going to say, be free to get in contact with me if you want more details about that.
Okay, and another question just came through about the guidelines while we're talking about them. Do they have guidelines for treatment of people in the community as opposed to the other people, I guess, that you were talking about in resi rehab or acute care settings?
Treatment in the community.
So I guess, do the guidelines cover more general care settings rather than acute?
So the guidelines cover alcohol and other drug treatment settings. And we do talk about, I guess, what we do discuss in terms of the evidence-based best practice is, although it's a guide for alcohol and other drug treatment settings, we do discuss practices that would be suitable to other treatment settings and community-based practice. I can't think off the top of my head if there's anything specific to community-based practice.
But there are things like outpatient treatment settings are covered with.
There are outpatient. Yes.
Okay.
Yes, they are. Sorry, I misunderstood.
I might be misunderstanding the question as well. So if I've misinterpreted your question, do let us know. But otherwise, as Chris said, you can contact her for more details about the guidelines. We didn't get you on here to answer questions about the guidelines, so
that's all right. I don't mind.
We'll move on from that now. Okay, so
I better do a webinar about the guidelines when they're done.
Yeah, that can be the next one. Okay, so another thing was just whether. So we saw that there was still some severe mental health problems at the 11-year follow-up, and were those people more likely to be the people that hadn't recovered from heroin, so that were still using or still dependent?
There were a lot of people who were still using at 11 years still did have a lot of mental health problems and vice versa.
Right.
But a lot of people with mental health problems at 11 years, I think, were not necessarily using. I think let me go back to the, if I can just scroll back to the numbers slide.
Because I
Sorry,
guess it
could you
also,
repeat
a
that?
related point is the fact that with the physical health, that was relatively stable, you mentioned. So it looks
Yes.
like, is it sort of the case that the damage is already done, do you think? Like, even though people have recovered, but it's sort of been done, the damage has been done earlier on in terms of physical health.
I not necessarily. I think that I guess I'd be cautious about saying that. For a lot of people, I think, we did see very severe physical health problems at 11 years, but I think that a lot of people did get better. So I don't know if you could say that the damage was already done, and I don't think we have the data to answer that question. What was I looking for?
The mental health, was it associated
Okay.
with, yeah.
So when we had a quarter of people were still using at 11 years, and we have major depression, a quarter of people were still using. I actually don't know. I don't think I've looked at whether they were the same people. I don't think that they necessarily would have been, but that's a really good question and something that I should look at.
Okay. Now, still talking about mental health, depression and other mental health disorders in general are correlated to poorer outcomes, so employment,
Yes.
health outcomes, etc. So how important, and again, this might not be something that you can answer, but just in terms of what you would say, how important do you think the presence of depression is in general as opposed to the addiction per se? So I guess all of the psychosocial problems that might go along with that.
We found that major depression was just particularly for this cohort, was just a really poor indicator of future outcome. I mean, across the study, at every single time point we looked at, it was associated with bad outcome, and not only bad outcome, but it indicated it was the strongest. It had the strongest relationship with every factor that we examined. So, what was the second part of your question? Sorry.
Is it about depression? Is it about the presence of depression in general as opposed to related to addiction per se? It's not possible to kind of disentangle that, probably.
I think it's difficult to disentangle, yeah. I think that, the mental health of this population was really, this study highlighted the fact that major depression and mental health was significantly related to poor outcome. And although people did get better, and I think, as I said, I can't say whether they were the same people who were still using it 11 years or not, because I can't, although the paper there might be able to shed some light on that. I can't remember off the top of my head. I don't think that we can tear those apart.
It's difficult too, isn't it? Okay,
Yeah.
Here's a really interesting question about, and I picked up on this as well, the big improvements in rates of crime, or people deriving crime from.
Yes.
Yeah, and so someone's asked, what do you think the reasons were for why crime as income was reduced? Is it because of being in treatment outcomes, non-report due to fear of reporting that they were in crime?
Yeah, that's a good question. I'm actually not sure. We haven't looked at that yet. It's something we're going to look into this year. We have looked at crime over 3 years, and we found that being involved, not having antisocial personality disorder, having stable accommodation and employment was associated with low levels of crime. So I'm not sure whether that is something that is going to carry through to 11 years. Or whether it's something different. We did find that I think past month criminal involvement it had increased slightly, but not very much, and the crime as a main source of income, it reduced enormously. Let me go back to that slide as well.
Yeah.
2%.
And in terms of whether it's a reporting bias, there'd be no reason for them to suddenly at 11 years be afraid of reporting on that when at baseline they were okay with reporting, would there? Or
It's definitely possible. I doubt it, because the way we asked about crime, we didn't ask for details about crime. We asked whether anyone had been involved in past month crime, and we, of course, because of ethics and being very sensitive about wanting to pry too much. We didn't ask about details or anything like that. What their main source of income was in the last month, whether it was from a wage, whether it was from government benefits, or whether it was from crime. That was how we phrased the question.
Okay, yeah. Okay.
So I don't think that, it's possible, of course, that could be it.
Yeah.
And it's also, I guess, possible that the people who were receiving crime as a main source of income earlier were in prison at 11 years and we hadn't been able to capture them. That's something.
Well, that was the other suggestion that this person had said. Is it sadly that people that were more involved in crime maybe were some of those ones that had died? So some of the, was it 11?
Yes, that's possible.
Yeah.
That's possible. We haven't looked at that yet, but that is definitely possible.
There's a lot.
Or it's possible that we weren't able to find them either. There was, a subsample that we weren't able to locate at 11 years. We don't know where they are. There were a proportion that we were able to locate, but we weren't able to lock in for an interview. It's possible that that's them as well.
Okay. All right, so now some questions here about that first 3-month period where there was real benefits going on there. What do you make of that? So this question is, does that infer that the study itself was an effective treatment approach? But I guess all of these people were in treatment of some kind anyway. So why do you think that first 3 months was so important?
I think the first 3 months reflect the impact of the treatment that people were in. Of course, there were 80 people who were not in treatment, and I haven't separated those from these results. But most of the people who were in the study, so 535, were in treatment. So they were either in residential rehab, they were in detox, or they were in maintenance therapies. And so I think that in the 3 months after baseline, this is reflecting that impact, not necessarily the study, although it's possible that it could be reflecting that. But I think it's showing the impact of that treatment episode.
So because they just entered treatment at
they just entered treatment when we first recruited them. Yes.
Yeah. Okay.
So in fact, at 3 months, some of them were still in treatment if they were in residential rehab. Yeah.
So it's really showing that in that first 3 months of treatment, they can make a lot of gains.
Yes, absolutely.
Okay. Now there's a question here about just in clarifying the treatment, was there community-based treatments included in those options? So there was resi rehab. Were some people in the study having treatment from a community-based treatment?
Community-based treatment.
So just not inpatient, I guess.
Oh, yes.
Right. Yeah.
Yes. So, that was,
So that's included in there as well. And do you have, can you tell us anything about what treatment looked like it was having the best outcomes over the longer term?
Sorry, what was that?
So which treatments, was it possible to separate out, so there were different treatments that people were going into, was it possible to separate out which produced the best results over the longer term period?
In a way, but people cycled in and out of treatment so much over the 11 years that although we couldn't tell, we can have a look at which treatments people were in at baseline and see what happened to those people over the 11 years. We couldn't necessarily follow them up in and out of all the different treatment modalities over time because although we followed them up 6 times over the 11 years, between the periods where we weren't able to follow them up, people changed in and out. So let me just... sorry, I know I'm flicking back and forth over all these slides a lot.
We're getting
here. Yeah, getting dizzy. Everybody spent some time in treatment at some point, and they cycled in and out so much that we couldn't necessarily tell the effect of specific types of treatment. However, we can look at what they started in at baseline and see that effect over time. So when I talked at the end about residential rehab being linked to the most improved outcomes in terms of stability and treatment over fewer episodes, and detoxification being linked to poor outcomes in terms of cycling in and out of treatment, and how detoxification can be linked to or can be used as a gateway into treatment rather than a standalone treatment.
Mm-hmm. Yep. Okay.
Um,
Why do you think resi rehab might be such a strong option then? I know you're not saying definitely, but there were those indications.
I think that the indications for residential rehab is that it has the capacity to provide a stable treatment that addresses the physical and mental health needs, so in a more holistic way for people over a longer term with fewer cycling in and out for people. So with an ageing population, perhaps, that has more need of physical and mental health treatment, it has the capacity to address that.
Okay. All right. Well, I've got one last question. It's a quick one, and then we'll stop grilling you. Someone's got here: was psychosis and schizophrenia part of the severe disability examined? And what were the outcomes by 11 years? So, did you look at those at all?
The severe mental health disability we measured with the SF-12, which is just an indicator of general mental health. It's not psychosis or schizophrenia. And severity is measured looking at a cutoff score below the population norm. So no, we didn't look at that. We weren't able to in this. We didn't actually measure for schizophrenia or psychosis in this study. Okay. Unfortunately.
Yep. Yeah. All right. I've got one last one that's a follow-up, just to squeeze in. Promise this one's the last one.
That's all right.
Given that we had those positives in terms of people recovering, do you think that reflected the natural course rather than treatment itself?
It's possible.
But there were some small participants who didn't receive any treatment. Is that the case?
There were people who started not in treatment, but they all ended up in treatment.
Okay.
So again, it is possible. Sorry, you cut out there.
I said so. Again, it's difficult to disentangle because people are going in and out of cycling in and out of different treatments or not having treatment.
Yeah. I think it's really difficult to answer that. The longer term studies and looking at risk factors over time and predictors of outcome, which is something that we're going to try and do as the next phase of this study, might be able to look into that a little bit more and kind of separate out the treatment and the treatment effects from heroin and the other factors. But as it is now, I don't know. Of course, this is, I guess, a natural history study in that we have followed people over time. So it would be something that would be good to look at and be able to answer that. If I've not been able to answer any of your questions to your liking, please get in touch and let me know.
Yeah,
I'm sorry.
And I was going to say we did have a lot of questions coming through, so we may not have been able to cover them all, but please do contact Chris. So I think you had your email address, didn't you, on the last slide?
I did.
So you're willing to be contacted if anyone has any questions or wants to follow up on any of the points?
Sure. And I've got some references at the end if anybody wants to look up any of the data that I've put through there, because there's a lot that I had.
Okay, fantastic. And so the video recording of this session will be available for download from our website, and in addition the handouts, so with all those references, will be available. And we would thank you again for joining us. It's been great to have all of your comments coming through and your questions and your engagement with the topic. And so we'd love you to join us for our next webinar. So the next one is coming up towards the end of May, 26th of May, with Associate Professor Tim Slade. And so you can register for that webinar right now and lock in your place. But apart from that, I'm sure everyone will join me in saying thank you very much, Christina, for a fascinating webinar and for being patient with all of our many, many questions. We just wanted you to get into that data even more than you already have. So it'd be great to hear more and perhaps hear more about the guidelines down the track. All right. Well, thank you everyone, and good afternoon or good morning.